Good evening. My name is Tangela Thompson, and I am project manager for the Sidney Kimmel Cancer Center in New Jersey. It is my pleasure to welcome you to tonight's Facebook Live event, Prostate Cancer Awareness. During our conversation this evening, we will cover information on prostate cancer screening, diagnosis, treatment, research, and resources. We are joined by medical experts from the Sidney Kimmel Cancer Center. As our panelists share their knowledge and experience, please do not hesitate to ask them questions. You may leave your questions in Facebook comments. We will try our best to answer all of your questions during this live event. To start today's Facebook Live, we would like to first introduce our amazing panelists. And I ask that you could please share a little bit of yourself with our audience. Let's start with Dr. Gamella.
Hi, thank you, Tangela, and thank everybody from the Sidney Kimmel Cancer Center for this great opportunity. I'm Leonard Gamella. I'm the chairman of urology. I've been involved with the Sidney Kimmel Cancer Center since the early days. And as the years have gone on, we have gotten more and more involved with community outreach and in educational programs. And I think this is just one of those aspects. So I do a lot of research in clinical care in prostate cancer, and I'm really happy to spend a little bit of time tonight talking about the #1 tumor, solid tumor in men in the United States. So thanks everybody for joining us.
Thank you, Dr. Gamella. Next, if we could hear from Mariah Cunningham.
Hi, everybody. My name is Mariah Cunningham, and I'm a third-year PhD candidate, and I'm researching prostate cancer in the lab. So I look at castrate-resistant prostate cancer, which is an advanced form of the disease, and I'm looking at PARP inhibitors and how we can treat advanced stage disease with PARP inhibitors.
Thank you, Mariah. And lastly, Joshua Blanding-Godbold.
Hello, everyone. Thanks for showing up to listen to us talk to you all about prostate cancer. My name is Joshua Blanding-Godbold. I'm a clinical research coordinator here at the Sidney Kimmel Cancer Center. I also do a lot of work with community outreach and engagement, work that I kind of was ushered into in the pandemic when a lot of my other work responsibilities were shut down. So I really enjoy working doing community events outside and participating in talks like this. Thanks for having us.
Great. Thank you so much for joining us today. And we would like to start our conversation with prostate cancer and its screening. Dr. Gamella, could you please talk to us about prostate cancer in general?
Sure, happy to do so. Prostate cancer, as I mentioned earlier, is the #1 solid tumor in men in the United States. And it is not the #1 killer. It's actually the #2 killer behind lung cancer. But when it comes to the number of cases out there, it is among the top of all the solid tumors that men in the United States can experience. So just some rough numbers for everybody. There's almost 300,000 cases a year of newly diagnosed prostate cancer in the United States. And about 35,000 men a year die of prostate cancer in the US. That's kind of big numbers, but if you take it down to individual, about every 2 to 3 minutes, a man in the United States is diagnosed with prostate cancer. And in their lifetime, on average, about 1 in 8 men will be diagnosed with prostate cancer. Now, we have a little bit of a challenge with that because when we look at these big numbers, when we look at the African-American community, those numbers are actually higher. That way, a Black man is almost 2 times more likely to be diagnosed with prostate cancer and almost 2 times more likely to die from prostate cancer. So a lot of important work is being done in this area. Why is there disparity between African-American men and their white counterparts? And we have colleagues like Mariah and Joshua helping us do some of those studies. But the answer is really not really clear, but it certainly is a focus. And when we talk about prostate cancer, we also have to recognize breast cancer, because breast cancer and prostate cancer are the leading solid tumors in Americans, and also each of them are the second leading cause of death. The difference between breast cancer and prostate cancer, though, is pretty significant, because when a lady develops breast cancer, she tends to develop at an earlier age and tends to die sooner than men with prostate cancer. So both of these cancers really do need a lot of our attention. So about 3 million prostate cancer survivors are alive in the United States right now. Those are people who have been diagnosed and treated for prostate cancer. And the good news is, when we find prostate cancer early, the 5-year survival rate is almost 100%. We do really well with early prostate cancer. But once the prostate cancer spreads to other parts of the body or becomes metastatic, that 5-year survival rate drops to about 35 to 40%. So one of our focuses, particularly with screening education, is try to identify the men at risk for prostate cancer and find it early when it's in its most curable and treatable forms. Now, a little bit about the prostate and prostate cancer. The prostate is a male organ, and the main job of the prostate is to make fluid for the ejaculant. So when a man ejaculates and sperm comes out of the body, the sperm is a very small part. The prostate makes most of that liquid. It's not a gland that makes hormones or anything else in the body. It really just makes the fluid for ejaculation. However, for reasons we absolutely have no idea, and hopefully researchers like Mariah one day are going to help us discover it, what causes prostate cancer? And we have all sorts of theories, and you would think such a common cancer would have an answer. In fact, we still do not know what causes prostate cancer. Lung cancer, you can connect with, perhaps cigarette smoking, melanoma, skin cancer with sun exposure. We still do not know what is the trigger for prostate cancer. But we do know is that there are certain men that are more at risk for prostate cancer. And these are the ones that we really want to focus our screening efforts on and try to find the cancers early. So cancer prevention, a lot of talk about it. We don't really have a good prevention for prostate cancer. What we like to say to our patients, it's what's good for your heart is good for your prostate. Exercise, green leafy vegetables, a low-fat diet, limited smoking, all sorts of healthy activities we believe are the best we can offer men really to prevent prostate cancer. But we don't have a definitive pill, an herb, an over-the-counter medication. So screening becomes very, very important to us, and detecting the cancer at an early and a curable stage when it's not spread beyond the prostate is very important to us. So screening for prostate cancer. I think everybody who has at least a little bit of familiarity with prostate cancer recognize it is very controversial. In fact, we have competing guidelines, depending on which medical organization you look at, that we should or shouldn't screen for prostate cancer. Well, how can that be? Well, the reason for that is that our main tool to detect prostate cancer early is the PSA blood test. Now, physically feeling the prostate can be important, where a gloved finger is placed in the rectum, because the prostate sits right behind the rectum, and we can actually feel the prostate for lumps or bumps or hard places. But honestly, what's happening today is that we are detecting these cancers much, much earlier before they actually form lumps and bumps in the prostate. So while the rectal exam is still done, at the end of the day, our main tool for the early detection of prostate cancer is a PSA blood test. Now, PSA is something called prostate-specific antigen. And that's just a fancy word for a compound that gets leaked out into the bloodstream. And for some reason that we have a little bit of an idea, when you have cancer, this appears to leak out into the bloodstream a little bit more than when you don't have cancer. But here's the challenge that we have. If a man has an enlarged prostate, if they have a prostate infection, if they've had recent sexual activity or been on a long, hard bike ride, their PSA may actually be elevated and they may not have prostate cancer. So one of the challenges that we have is that many men with early prostate cancer have don't have or without prostate cancer have an enlarged prostate. And simply an enlarged prostate can put more PSA out into the blood. So that's one of the reasons that the PSA screening blood test is a little controversial. A bigger reason why the PSA blood test is probably controversial is PSA is so good at allowing us to find early prostate cancers. Many of the cancers that we are now finding are not life-threatening. They don't metastasize. They don't spread outside of the body. And in fact, there's a term that we have in the world of urology and medical oncology, primary care medicine. More men die with prostate cancer rather than of prostate cancer. And exactly what does that mean? Again, for reasons we don't understand, as men age, most of them will develop a little spot of cancer in their prostate that will never harm them. And in fact, if you start looking at autopsies on men who are in their 80s or 90s, who have no history of prostate cancer, and in the autopsy, you go and you look at their prostate, many of them, probably 80 to 90% of them as well, will have a little spot of prostate cancer. So the challenge that we have is we don't want to pick up these non-life-threatening cancers. We really only want to pick up the life-threatening cancers. So that's a little bit of the reason that screening is controversial, because we're subjecting men to treatments for cancers that may not necessarily ever harm them in their lifetime. Now, put that in context, however, we now have a completely different approach to prostate cancer treatment that I'll talk about in a couple of minutes as something known as active surveillance. So screening for prostate cancer is our best tool to prevent death and other problems from prostate cancer, but it's not without some challenges as we recognize. Now, the current normal number for the PSA blood test is 2.5. Most laboratories will say either 2.5 or 4.0. As you get a little bit older, some men naturally have a little bit higher PSA, and it's up to your doctor to kind of look at you and look at your PSA blood test and decide what goes on. So that blood test is the best way that we have to detect early prostate cancer, and it also picks up late prostate cancer as well. You know, men may come in with a number of 10, 15, 20, or even higher. Those are the ones we really worry about when they come in with a first ever PSA. And those men with the extraordinarily high PSA numbers are more likely to have advanced or metastatic prostate cancer. So when we talk about screening, we talk about some of the controversies. Depending on which guideline you look at, I like to use the American Cancer Society guideline. You can look at other guidelines from other organizations. But basically, the American Cancer Society suggests that most men have their first PSA blood test around age 50. If you have a family history of prostate cancer, or much more importantly, if you are African American, that usually should start around age 40 to 45. But it's very important that with that screening, you have a conversation with the doctor about the risks and benefits of screening. Screening may pick up cancers, and it may miss other cancers. So it's also important to recognize the PSA, I like to describe as a smoke detector beeping in your upstairs bedroom. Just because that PSA is elevated, just because that smoke detector beeps, doesn't mean there's a fire. However, it brings your attention that there may be something going on in the prostate. So screening for prostate cancer is just that. Let you know somebody may be at risk for having prostate cancer. Today, the only way that we can actually diagnose prostate cancer is by putting a needle into the prostate gland and taking little samples out of the prostate and looking at under the microscope. So diagnosing early prostate cancer is based on an abnormally elevated PSA, maybe an abnormal feel of the prostate, but also much more importantly, it has to look at under the microscope. And when you look at the cancer under the microscope, that's when we get to the next stage. Now, what I want to talk about next is treatment for prostate cancer. I want to break that into two parts. The first part, we're going to talk about early prostate cancer. In other words, cancer which is just within the prostate and hasn't spread anywhere else. That's where we're having our most success today. So, keeping it very simple, there are three general approaches to treating early localized prostate cancer. Those are what we call active surveillance, radical prostatectomy, where the entire prostate is removed surgically, or some type of radiation where you shoot radiation from outside the body. And those are the very simple high-level treatments. Now, you might say active surveillance doesn't sound like a treatment, but in fact it is. And that's one of the advances that we've made in reducing the controversy about treating advanced prostate cancer, treating all cases of prostate cancer that don't need to be treated. In fact, today, most men diagnosed with early prostate cancer, probably 50 to 60%, have non-life-threatening, non-aggressive prostate cancer that we can simply follow. We follow them with things like an MRI or a CAT scan, follow them with blood tests, and maybe periodically do another prostate biopsy to make sure nothing's changing. However, if a man has a little bit more aggressive prostate cancer in the prostate itself, then we go on standard treatments, and that's either the surgical removal of the prostate or shooting radiation at the prostate from outside the body. Both of these are very effective, and which one is right for a patient is a whole separate discussion, really, that you have to have with a team of experts, your own primary care doctor, as well as experts in surgery and radiation for prostate cancer, and have the decision what's best for you. The good news is that as I mentioned earlier, the 5-year survival rate for early prostate cancer is 100%, whether it's treated with active surveillance or treated with one of the type of surgeries. When we find cancer outside of the prostate, completely different story. It usually has to be treated with some type of drug that lowers your testosterone. Why is that? Testosterone acts like a fertilizer that allows prostate cancer to grow. Testosterone does not cause prostate cancer, but it acts as a fertilizer. So one of our first strategies when the cancer is spread outside the body is to lower the testosterone. After that, we have almost an amazing collection of drugs. Some of them Mariah is investigating to treat men. In fact, since 2010, we probably have developed about 12 to 15 new drugs to treat advanced prostate cancer. So I think this is very, very, very good. Very good news. We're making a lot of progress in the treatment of prostate cancer. And yes, there can be side effects of treatment with localized prostate cancer. But again, today we have different strategies to reduce the common side effects of treating prostate cancer by either surgery or radiation. And again, that's good news for men. We are doing much better. So I think that is I hope a quick overview of kind of an A to Z approach to prostate cancer, from screening to prevention. Again, our best defense is early detection. Early prostate cancer is usually without symptoms. In other words, people talk about, oh, if you have blood in your urine or if you have trouble urinating, things like that. Most of the time, some of those things have nothing to do with prostate cancer. They tend to due to a simple benign enlargement of the prostate. In fact, benign enlargement of the prostate affects many more men than does prostate cancer. So the minute a man starts having symptoms, don't panic. Don't immediately think, oh my goodness, I have prostate cancer, because so many men will simply have benign enlargement of the prostate, which can be completed completely differently. So again, if you have questions, there's a lot of good resources out there. I always advise patients, stick with the big known websites such as the Sidney Kimmel Cancer Center, Sloan Kettering, Johns Hopkins, our friends at the Abramson Cancer Center, American Cancer Society. Again, stick with the big websites if you want to look up information about the prostate in general or the prostate cancer specifically. Stick with those websites because you're going to get the most trusted and most reliable information from from everybody. So again, I look forward to any questions that everybody may have, and I thank the Sidney Kimmel Cancer Center team for putting this together tonight. So thanks to everybody.
Thank you, Dr. Kimmel. We do have a couple of questions from our Facebook audience. One question is for you. You mentioned some populations are more at risk than others. I know Black men are more likely than white men. Have you seen any patterns by immigrant status or refugee status?
That's an interesting question. I don't think we've seen a few of our newly arrived immigrants in our practice, and I can't say that we've seen enough of them to really make any kind of general general statement about it at this point in time. And I'm sure as the years go on, we'll have a little bit more to add to that question. But at least right now, when they come to our office, they're receiving the same type of screening and evaluation that any other patient would get that would come into our office.
Okay, another question. Can non-life-threatening prostate cancer change to life-threatening prostate cancer at a later date of time?
Yeah, that's a great question. And that's why we need people like Mariah and people like Josh who are doing clinical trials to really look at that. We do follow patients with newly diagnosed early prostate cancer. And I will say with confidence that the majority do not change over 5 to 10 years. It's almost like a chicken and an egg. If you hatch a non-aggressive prostate cancer, it tends to stay that way for many, many, many years. If you hatch a more aggressive cancer, it actually can get more aggressive as time goes on. So that's actually a great question. Most of us, again, there's a little controversy, but most of us to believe that when you have that initial prostate cancer and it's detected, it tends not to become more aggressive with time. Tends to. There are exceptions, and that's why we do periodic biopsies every couple of years in patients with early prostate cancer to make sure nothing's changing. But I think I can say with a fair amount of confidence, most men do not change their Gleason score, which is a measure of aggressiveness of the cancer over the years.
Okay, Dr. Kimmel, I actually have a question. For many males, what I've heard as a concern is, say, for instance, the biopsy process. Is that painful?
So that's another great question. So traditionally, the biopsies have been done through what's called a transrectal approach. What does that mean? We mentioned earlier that you can feel the prostate through the rectum. So what has been traditionally done is a ultrasound probe, which is about the size of my thumb, is placed in the rectum. Local anesthesia is injected, and the biopsy is done alongside the ultrasound probe in the rectum. That's been the standard for 20 years. I will tell you that over the last 2 to 3 years, there's been a big shift away from that. And the biopsies in many places in the United States and almost exclusively in Europe now are biopsied not through the rectum, but through the skin between the base of a man's scrotum and his rectum, because that's where the prostate lives, with anesthesia. And we're finding that men are much more comfortable doing it that way. It is a much more a genteel procedure, and we're shifting that way. One of the big reasons for the shifts beyond men's comfort level is infections. We were starting to run into a lot of men with infections through that traditional transrectal biopsy approach, and that's been cut down dramatically through this new approach. And the term is transperineal biopsy, where the needle goes through the skin between, again, the scrotum and the rectum. And that's become much more common. And a lot of men like a little bit of anesthesia with it and are much more comfortable.
Okay, and what I think may be a final question is, does treatment for prostate cancer automatically, or does it definitely equate to being impotent for men?
So that's a good question. So the new treatments for early prostate cancer, we try to do what's called nerve sparing. If we're going to do surgery, there are critical nerves that are connected to the prostate that control erections. So we try to be very mindful about protecting those nerves with surgery. Radiation's a little bit trickier, but the bottom line is that if we do have that side effect from the treatment of early prostate cancer, again, we have at least 5 or 6 different techniques and approaches that we can to help a man with difficulty with erections. So yeah, that's one of, again, we mentioned that as one of the side effects of some of our treatments, but they're getting less common, and we have certain strategies that we use now to try to limit the loss of erections. But more importantly, we have ways now to bring erections back effectively to many men who may suffer from that problem.
Thank you, Dr. Kimmel.
Thank you.
Mariah, could you talk to us a little bit about what your research focuses and how it affects prostate cancer patients?
Yes, so my research focus is on studying advanced stage prostate cancer, also known as CRPC or castrate-resistant prostate cancer. And I'm looking at a drug called a PARP inhibitor. PARP is an enzyme that binds to damaged DNA in our body and sends a signal out to repair that DNA. Unfortunately, this protein works a little bit too well in some patients, causing cancerous cells to repair DNA and replicate. And PARP inhibitors basically work by inhibiting PARP's ability to repair or send out signals to get DNA damage repair enzymes to repair the DNA. PARP inhibitors are a type of drug treatment that's approved currently in breast, ovarian, pancreatic, and prostate cancers. And cancer patients are typically eligible for PARP inhibitors if they have something wrong with their DNA damage repair genes, most commonly BRCA1 and BRCA2 genes. And these proteins help to fix damaged DNA. If they're messed up in any way and PARP activity is inhibited with a PARP inhibitor, then they can help stop tumoral growth in patients. In my research, I've been using it in prostate cancer, and we do see that there's a benefit in the cell lines anyway that don't have DNA damage repair enzymes messed up, which suggests that this inhibitor may be able to be used for a larger group of patients, not just patients with the damaged BRCA1 and BRCA2. And I'm mainly focused on trying to figure out which patients can benefit from this PARP inhibitor treatment, even if they don't have the historical mutations in BRCA1 and BRCA2. And something that has really been good for me in driving my research is when I was doing early on researching and reading papers, I noticed a lot of papers said that African-American men are 2 times as likely to develop the disease as Dr. Kimmel discussed, and about 2 times as likely to die from the disease in their lifetime. And typically African-Americans tend to have a more aggressive form of the disease. So this sparked a curiosity in me and really made me want to look at the aspect of race in my project, as well as looking at the PARP inhibitor response in my project. So I did some digging, and I've been looking at some clinical trials for just for like the translational part of my project. And I noticed that in one of the bigger clinical trials that was more pivotal, I think started in 2017, but results were given in 2022 or 2023, almost 3% of the cohort were African-American. And that's out of a group of 400 men. Only 3% of the patients were African-American in this trial. So for some perspective, about 70%, not like 100%, but about 70% of the men in that trial were of European descent. And considering that African-Americans tend to have more aggressive form of the disease and that we are dying more from it, I think that the number should definitely be higher on the clinical side, but also on the basic research side. Because for me, one of my interests was, okay, I have cell lines in the lab that I'm working with, and they're derived from European American men usually. So when I started digging and doing some work on that, I found that there's very few African American derived prostate cancer cell lines for me to even do my work at the basic research level. So what's driving my interest in research and interest in this part of my project really is my community. Because when I talk about African-American men experiencing it more, I think of my uncles, my dad, my brother, my boyfriend, like all these important Black men in my life are potentially going to suffer from this disease more. And actually 4 out of 8 of my uncles have had prostate cancer. They are all survivors, but still, like, the fact that most of my uncles have had the disease is also what's driving me to want to look into it and figure out different ways that we can potentially treat the disease. And for me, basic science affects prostate cancer in the sense that science is based off of community in a sense. So, and research impacts community. And I've learned that a lot through SKCC and doing programs like this. For example, for PARP inhibitors, if a drug like a PARP inhibitor is seen to work well in clinical trials, then we can use that drug for patients. So I work with PARP inhibitors, and my PI, or my boss, Matt, found that PARP inhibitors worked well in prostate cancer, and that was actually one of the papers that clinical trials used to approve PARP inhibitors in prostate cancer. And now that we know that it works in prostate cancer patients, I'm doing further work to see if we can make them work better or more effectively within those patients. So my project is really focused on expanding or broadening the amount of patients that are receiving PARP inhibitors for prostate cancer. And one thing that's important for me, no matter what, is pursuing my PhD, is having the work being impactful at a patient level. So I want my research to be translational. Like, whatever I do in the lab, I want it to help somebody in the clinic at some point. So just like community impacts research, the research that I will do will impact the community and may increase the amount of patients that are receiving the drug that I'm studying. Yeah. And I did want to reiterate what Dr. Kimmel said, that there are certain communities and populations that are more at risk for prostate cancer. Again, the African-American community is more at risk, older men, and if you have a family history of the disease. So yeah.
Okay. Mariah, do you have any perspective on why being African-American or being of African ancestry put you at a higher risk for prostate cancer?
Yeah, so that's a great question. So I have been reading a lot of papers about that, and I think that there's a lot of different talk in the literature, so I'm basically just going to do a brief overview of what I've seen. So one big issue has been socioeconomic status. That is like the main issue people try to push, like, oh, if they have better care, then they'll be able to their prostate cancer will be fine. Like, it's because of the fact that they don't have the right healthcare and stuff like that. And although that is a factor, I've also seen more recent papers that are looking at the biological differences. So they're looking at their genes and the mutations and the things that are wrong with their genes. And when you compare African-American to European-American genes, there are differences in the mutations in their genes. So while European-American males may respond better to drug X, it might actually be worse for African-American because of the difference in their genetic makeup, which leads us to like personalized medicine and like prioritizing that as just like looking at those factors. So I don't as of right now, there's not a clear answer, but I think we are slowly working towards trying to figure out why, on the basic research side as well as the clinical side.
Okay, and I know initially you were speaking about clinical trials. Have you come across any information which might suggest why African-American males are less likely to wind up in a trial?
That I'm not sure of. I know that I've read that, for example, in one paper, they looked at the fact of access to care, and in African-American communities, it tends to be the hospitals tend to be farther out, so it might not be as plausible for them to want to go and try and enroll in a clinical trial because of that. That's the only paper that I've actually seen, like, with data as to why it might be low. And I think that another thing that we should probably consider is like the Tuskegee experiments, even though those were like a very, very long time ago. That's something that I definitely hear when I go out in the community as a reason as to why men are a little more scared of coming and getting like involved in clinical trials or clinical research at all, which is why I think it's really impactful for us to go out in the community and to have events and just talk like this, because I know that the community respond, like when you see somebody that looks like you, I think it helps a lot. And I think like for me, that was something, because I've planned 2 prostate cancer events in my community at an African-American church, New Covenant Church of Philadelphia. And I feel like that's something they really told me that they appreciated, is like seeing people that look like them, telling them about this disease and clinical trials. And Josh actually did a great presentation on clinical trials and really breaking it down so that people understand like what they're getting into, and understanding like that it's not something that's scary, and it's something that will not only might help you, but it might help other people as well.
Okay, that's great. Thank you, Mariah. Josh, would you tell us a little bit about your research focus and how your research affects prostate cancer patients?
Sure. And I guess I'll start by touching on the question of why we think there are fewer African-American men participating in clinical trials. I think what Mariah said is accurate about just general distrust of the healthcare infrastructure in this country based on previous negative events that have happened throughout history. I think there is also barriers to access where hospitals are located, where clinics are located, who has health insurance that pays for regular physician visits, whereas where a lot of people actually find out about these trials. So there's a multitude of factors. But just to kind of segue into that, the project that I've been working on for the past year and a half or so at Jefferson has been a prostate cancer and genetic awareness and education research project specifically for African American men. So we did that because the rates of African American male mortality rates for prostate cancer are so high in the city of Philadelphia. And generally, the city of Philadelphia tends to have higher cancer rates and cancer mortality rates than the surrounding area and the national averages. So what our research project was talking and recruiting African American men in the area and enrolling them in a trial that gives them access to education about prostate cancer. So a lot of the scientific facts, that I'm not an expert on, but people like Dr. Kimmel and Mariah are experts on, we would try and impart that to the community and then encourage them to receive genetic testing for prostate cancer. And the genetic testing is a positive tool, we think, to give people a snapshot of their genetic makeup and their family health history in terms of if prostate cancer is hereditary, could that be the case for you? And could that give you a jump start on possibly talking to your doctor about a schedule for screening at a later point in your life? So we wanted people to kind of know what that genetic testing process is. And really what it is talking to your physician, because you usually need to talk to a physician or a urologist to get in contact with a genetics department at a hospital or a healthcare system near you. And then you would talk to a genetic counselor about your family health history, any symptoms you may be having, and then they would give you a rundown on the pros and cons of receiving the genetic testing. So like Dr. Gamella said, a lot of men may get symptoms of prostate cancer, or not symptoms, but they may have an issue with the prostate that is not life-threatening. So we don't want people to receive something on a genetic test and equally get alarmed by the findings. We want them to be talking to an expert, somebody that understands the risks and how those risks can affect the men getting the test and their family members. So that's just specifically what my one project was about. But generally, most people don't know about clinical trials. So just to briefly cover that, clinical trial is a research study that's designed to test the safety and effectiveness of different drugs, devices, surgery, treatments, or preventative measures in human test subjects. And a human subject is a volunteer participant, so it is never, a mandatory thing that you have to participate in a clinical trial. And there is an informed consent process in which you're told all about the trial, the pros and cons, and you're given a chance to respond to the question, are you a willing participant in this clinical trial? Okay, so typically clinical trials have 4 phases. I won't get into the nitty gritty of each of those phases, but generally they go from small populations to larger populations. So a phase 1 trial has a very small group where they test the effectiveness and safety of a drug. And then as they move through the phases, the population in the testing pool gets larger and larger to make sure that there are no side effects once you introduce different populations and larger populations into the trial. So generally, also, there are some risks and rewards to participating in clinical trials. Some risks may be some treatments and drugs have side effects. Those will be explained, and those side effects are always being minimized for the participant in the trial. So they want trials to be a comfortable experience, but they also really want to know, what is happening with the drug, what's happening in different gene pools, different populations, and how, like was said previously, how different treatments respond in different human test subjects. So just to cover the informed consent process, if someone has never participated in a clinical trial, they may not be familiar with this process. So the informed consent process is a piece of paper that's either read to you or you read it yourself when you're signing up for a trial. And it really is supposed to describe fully what the purpose of the study is. If there are any tests or treatments involved, it'll describe what those are and what the potential side effects might be. If there are any costs involved, that will be described in this process as well, and how this could affect your daily life. So for one example, if you need to travel to a physical site to receive treatment, that will be described in the consent. Sometimes those travel costs will be reimbursed for the participants. Anything that could affect your life, headaches, anything that could affect your daily life will be described there. So you have full awareness of what's going on before you choose to participate or not. And then just briefly, a lot of people don't know how they can access or find clinical trials. So the largest resource that you could probably access is clinicaltrials.gov. This is a website that you can search through for specific trials based on disease type. So you can search for different types of cancer, diabetes trials, Alzheimer's trials, anything that you can think of. A trial is there. You can filter and search for male or female, or trials that are accessible to anyone by age group, what have you. And then also the Sidney Kimmel Cancer Center has a website that's jeffersonhealth.org/clinical specialties/cancer/clinical trials. If you Google Sidney Kimmel Cancer Center clinical trials, that site will come up. And then you're specifically filtering through the trials that we have at the SKCC. And then you can do that for any local hospital near you, Penn, Johns Hopkins, Cooper, what have you. Okay, I think I see some questions coming in.
Yes, I have a couple of questions. So I think you pretty much covered how someone would enroll in a clinical trial. Can you tell me or speak to whether or not there's a specific gene that placed men at a higher risk for prostate cancer?
Sure. So Mariah spoke to the BRCA1 gene, I believe. So the BRCA1 and BRCA2 genes are genes that, and if I ever misstep and confuse the science, I'll let the scientists hop in. But they're genes that stop the formation of tumors in the body. So when there's a mutation in these genes, it kind of messes with the body's defense mechanisms with stopping cancers from forming. So these are just one of the genes that if you were to get a genetic test for prostate cancer done, they can identify any mutations in the BRCA1 or BRCA2 genes, and that'll give you a sense of if there may be an issue down the line. Not that that would be specifically life-threatening. It's impossible to say what will happen in the future with these things, but it'll just, I guess, pique your interest and give you something that you can bring to your doctor and discuss further in terms of your screening process going forward. There are also genes that that we know are associated with more aggressive and advanced prostate cancers in younger men. So if those genes popped up on a genetic test, then your doctor may advise you to get screening at a younger age than the controversial ages discussed before, which were 50, 60, 40 to 45 if you're African American. So there's a lot of different variables based on what genes pop up in that genetic test.
Yeah, if I could, that was an outstanding explanation. If I could just frame something a little bit, it turns out that the majority of patients with prostate cancer have no known family history. And that's something we have to remember. In fact, probably 70 to 80% of men who get prostate cancer, they don't have a father, brother, uncle, grandfather. However, as Josh mentioned, once we identify someone with a family history, then the genetic testing really becomes important. And that family history is not just for prostate cancer. Joshua talked about the BRCA1, the BRCA2 genes. They both are involved with the development. They don't cause the cancer, but the development of both prostate, breast, and other cancers. So while most men do not have an identified genetic alteration that you can detect, as Josh mentioned, once you find it, it becomes very critical, not only for screening, but also becomes critical for drugs like Mariah spoke about, because those PARP inhibitors tend to work better in men with prostate cancer with those BRCA1 and BRCA2 genes. And unfortunately, men with those genes tend to develop more aggressive forms of cancer. So a lot of research being done. We're going to learn a lot more about this in the coming years.
And I also just wanted to touch on that. You guys did a great job. So from my reading and some of the things we've seen in the lab, I know that, for example, RB1 is higher in African Americans, and that is a gene that has also shown to have more aggressive form of the disease. And the difference that I was talking about earlier, as far as genetics with African Americans versus European Americans, African Americans tend to have a higher immune response than European American men, which they're thinking might be the reason that they're having a difference in response. So I wouldn't necessarily say that it has anything to do with them being more predisposed to it, but those differences could be important. And for me specifically, with the PARP inhibitors, I'm trying to figure out if they might work better or worse in African Americans, because based on the clinical trial that I talked about earlier, that was only 3% African Americans, it seems like PARP inhibitors work worse, but it's way too small of a number of African Americans on that trial to actually make a conclusion if those inhibitors work better or worse in African Americans.
Okay, thank you. There's another question for Dr. Kimmel. Or if someone if someone decides that they only want to do a PSA instead of the digital rectal exam, is that acceptable for prostate screening?
That's a great question. Absolutely. In fact, that's how most of our screening programs are set up today. And why is that? PSA was really discovered in the 1980s and really came into clinical use in the early 1990s. So before PSA came into existence, you had to have a really big cancer to feel it. And unfortunately, most of the cancers were detected at a later stage. As we move forward using PSA testing, we're now actually able to pick up these cancers when most of them are much smaller. So if you look at most guidelines today for screening, they will say a PSA blood test with or without the digital rectal exam. And certainly the rectal exam, as a urologist who's treating patients with prostate cancers, is important once you've been diagnosed. However, for screening purposes, it's not as critical as it might have been 15 or 20 years ago. And I think this is a good thing, because I think this is encouraging more men to go out and have a PSA blood test where it's appropriate.
Yep,
Okay, great. Mhm.
just to add on that, that's something that I found in my research talking to men in the community is the apprehension to the digital rectal exam is very much present. And also there's a lot of confusion around the digital rectal exam and colonoscopies. But a lot of education has to be done on the difference between the colon and the prostate and the cancers there and the differences between those screenings. So I had to do a lot of, that kind of parsing out the information and letting men know that there are other options for screening available to them.
Okay, that's great. I have a question, and I guess whoever can best address it is how is genetic testing info used beyond just prostate cancer screening, if that is initially what someone comes in to get screened for, and they find that they may not have an issue with prostate, but then what happens with the rest of the information, or how is it used beyond that?
So when I talk about genetic testing, I'm not talking about, like a 23andMe or an Ancestry.com type of company that uses your genetic information and then resells it or repackages it or somehow turns a profit on it. When you go to, for example, the genetic counseling department here at Jefferson, your tests are isolated to you. So you and the counselor discuss that information, and then we don't sell it, we don't send it to someone else. So you can be assured that if you go to a reputable hospital, your information isn't being sold. But also, once you're going through the process of getting the test done and talking with the counselors, if that's a concern for you, that's definitely something you want to bring up and talk about in person. And then that the paperwork you receive should also give you assurance of that and let you know that where the information is going or not going once you're done with the testing.
Yeah, and I appreciate you mentioning that, Josh, because these online do-it-yourself ordering of genetic tests are a little scary to us because, they may open up a can of worms that you really had no idea that you had to deal with. So at the Kimmel Cancer Center and the other major cancer centers, we rely very heavily on genetic counselors. These are master's level people. They are certified by the state of Pennsylvania to actually sit down, and if there's a concern about a genetic component to the cancer, they'll do a whole family tree. They'll look at your relatives. They'll look at the type of cancers, and then they'll give you an objective reading and say, Mr. Jones, based on your family history, you probably don't need to do any further genetic testing. Or what happens sometimes is, hey, Mr. Jones, there may be something going on in your family. You might want to talk to other family members coming in and being screened. The classic one is Angelina Jolie, who back in 2013 brought to the world that you could inherit cancer from your relatives. And that was a big breakthrough because now people are beginning to understand, again, in prostate cancer, it's probably only about 20% or so, but when you find it, it's very important. And again, other cancers are related. There are a relation between, as Josh mentioned, colon cancer, breast cancer, melanoma, pancreatic cancer. So we talk about BRCA1 or 2, these abnormal genes in prostate and breast, but they can be active in other types of cancers. And again, that's where we believe a genetic counselor can do the best service to a patient or a physician who's schooled in genetic testing.
Thank you. This about concludes our Facebook Live session on prostate cancer. I think that one of the things that stands out for me is how important screening is, and also education and outreach. Because if we can get in front of people, as Mariah spoke to, and touch folks who are disproportionately at risk for prostate cancer, and encourage those who might not otherwise seek screening or seek services, and get them to the doctor as quickly as possible, then they certainly have a better chance of beating cancer. And that is ultimately what we all want to see. So thank you for joining us this evening. And we look forward to having other conversations and talks regarding cancer and services that are available through research and ways to reduce your risk.